Welcome to the Ultimate Dental Podcast, the place where you can learn how to create a dental practice and a business life that you love. Listen in with Dr. David Moffet as he interviews successful entrepreneurs and successful business people and successful dentists as they share their business successes, their stories, and their breakthrough ideas, sharing pearls of wisdom that you can take back to your practice and implement immediately so that you can have that great practice with more patients, higher profits, and less stress. This is the podcast where great dental practices meet with successful business processes. Thanks for tuning in to the Ultimate Dental Podcast, the podcast where thought leaders, industry experts, and thriving practice owners reveal their very best tips, tools, and strategies that will help you grow your dental practice faster. Now, here's your host, Dr. David Moffet.
Hi, everybody, and welcome to today's episode of the Ultimate Dental Podcast. I'm your host, Dr. David Moffet, broadcasting from New South Wales in Australia, and I'm talking this afternoon in Australia, but this morning in Vienna to Dr. Barbara Bulla, who is really a doctor. She is a doctor as a dentist, but she is also now a doctor of medicine as well, a medical doctor as well as a dental doctor. So she's got the full house. If you're playing cards against her, she would win. So let me introduce you. Barbara, welcome to the Ultimate Dental Podcast. Thank you for joining me.
Hi, David. Thank you for inviting me.
And
it's an honor.
6:30 in the morning there, so I really appreciate you getting up early. Barbara, we've been talking to you for some time now, and following your career, we were originally attracted to speak with you because you had an interest in educating dentists and dentistry about some of the myths of HIV and treating HIV patients, and we'll come back to that. But as I mentioned, you have now graduated as a doctor, and you're based in Vienna in Austria, and you were telling me that you now, to be a max fax surgeon, you have to have an oral surgery degree and a medical degree and a max fax degree. So how many of those have you got at the moment? Because it sounds to me like you really are collecting degrees. And where are you heading with this as a career?
Well, in most countries in Europe, I don't really know if I'm speaking for every one of them, but in Austria for sure, we have to do first the medical degree, so become a dentist. So you can do either dentistry first and then medical school, or the other way around. I did dentistry first, and then I worked as an oral surgeon for a few years. And while working as an oral surgeon, I also did the medical degree. And after you have both degrees, you can specialize into maxillofacial surgery, which is not a separate degree on itself. It's a medical specialization. So this was all the university I intended to do. I hope I will only work from now on.
Oh, well, congratulations, because it is a lot of study and it is a lot of work to get to the position where you are, and of course there will always be need for max fax surgery, be it because of trauma or be it because of cancer or disease or illness. There is, and it's complicated in there. All dentists know that. From their anatomy days, just working on cadavers, it's very complex in there. So to be actually responsible for putting people back together, that must be an exciting career for you.
Yes, I am very excited to do it. I was thinking for a while that I might want to go into tumor surgery, but I think that in orthodontic surgery, I have the satisfaction of creating something beautiful, and that is something that I would want to do. So I think I will specialize into orthodontic surgery or maybe trauma surgery within the face.
Yeah, so it's sorry, I shouldn't laugh, but there's a lot of orthodontic surgery just correcting extraction orthodontic profiles where adults have had their premolars removed and their faces depressed in the oral cavity where they should be forward, and that's quite physically scarring.
Yeah.
A really bad treatment that was done back in the 60s, and now hopefully not done so much. But I think in it being able to give people some form of normality or expected normality for a deformity that is not their fault, I think that would be very rewarding as a career.
Yeah, I believe so as well.
So
Yes.
you also mentioned to me that you've done a Botox and fillers course, and of course that would go hand in hand in terms of not just getting the bones in the right place, but also helping to make sure that the scarring and the dermal anatomy is restored at the same time. Nobody wants to have multiple operations, and we're seeing this now also in breast cancer treatment as well, where the surgeons aren't just taking out the cancer and then they go to the plastic surgeon. A lot of plastic surgery being done at the time of the removal of the tumor. So again, exciting times for you. Tell me, how did you find doing that dermal fillers course, and do you see doing that as a standalone procedure, being part of your resume or part of your armamentarium as a specialist?
I actually really liked the course. I was convinced by a friend to do it, and we did it together. And just by visiting the course, I learned how broad the things are that you can do with dermal fillers and Botox as well. And the aspect you talked about with the scars, that was something that really was intriguing to me. I would love to give my patients a care that is as comprehensive as possible. So not just by, working on them, but if along the way some scars occurred, and I want to be the one who can also help them resurface the skin over the scar and maybe just make it more blunt and just give them a face as beautiful as possible.
Oh, really, really
So,
important. That would definitely be inspiring for the patients, because sometimes the thought of surgery is something that people just don't want. They don't want the scarring, and so they just manage with what they have. Tell me, as I've mentioned earlier, you began with an interest in HIV and AIDS. Can you tell me about that?
yeah, so what I've experienced with colleagues and just at university, so kind of made me look into HIV a little bit more. So since I first studied dentistry, I just learned about some oral manifestations at university, and then we were led into this path of sometimes working with HIV positive patients in the university clinic. And I actually studied general medicine afterwards. And that's when I got to work together with an HIV specialist doctor. And his way of treating patients was really affecting me, because he was just so normal to them, and that was so weird and new to me. That's not something I've experienced before. And that was the time when I was starting to question a lot of things. And yeah, that's when I looked into HIV a little bit more. Just to put this into perspective, the things I was starting to question were the rules that we thought we had to adhere by. So like a lot of dentists were saying or thinking that there are legal obligations or just like hygienic rules that we have to follow as dentists whenever we treat a person who admits to having HIV. And I was kind of feeling weird about it, because the people who usually admit to having HIV are the ones who are barely transmissive of the virus. So that's why I was starting to question all the things that I was living by as a dentist when I was working with this specialist. And I researched some guidelines, And then when I found out that most of the rules that we had thought that we have to live by were not really existent, it was just some urban legends that everyone accepted as it was, or not everyone, but like most of us. And yeah, that's when I started to research HIV itself a little bit more, and I started to educate the people around me, and then this circle got a little bit bigger. I started educating a little more people, not just the ones who are, working closely with me. And yeah, that's how I found out how interesting this is and how wrong some people's aspects on treating HIV positive patients were.
So let me get this right. There's a lot of myths and taboos out there that have no justification. There's no reason for them except that somebody once said that's what we need to do. Is that correct?
Yes. Yeah. So, whenever a patient comes, I think most of us dentists have been part of a situation or a scenario where a dentist came into so a patient came into the dental practice and admitted to having HIV, and then the tiptoeing and the talking quietly starts, where everyone asks like, what should we do? How should we act with this patient? And when you actually think about it, the patient who admits to having HIV is 75% likely to be on meds, on the right meds, and on the right dosage of meds. So they are not the ones that we actually have to be afraid of, the ones who do not know about their HIV. Those are the ones who tend to infect other people. So the ADA and the WHO have published data that says that 80% of new infections come from people who do not know that they have HIV. And us being overly protective about ourselves is kind of giving off the wrong image to patients who are less likely to infect us. So going by this, we should actually be afraid of anyone who has a tattoo or has received a blood transfusion or an organ transplantation, or so like there are so many risk factors that might infect someone with HIV, and those are potentially the people who do not know about having HIV. So it would make more sense to be afraid of everyone else than the ones who admit to having HIV. That's what kind of got to me, and that's why I started to talk about this.
I think back to my days when HIV was discovered. I think I was still in university, but the overlying principle was that we should treat everybody with the same level of sterilisation as if they have HIV, and we just don't know about it. Everybody deserves that same degree of cleanliness and sterility, and so it got us to raise the bar. I do remember, dental practices in Australia getting signs that said all instruments and handpieces are autoclaved per Dental Association guidelines. Well, that's just telling people what they already assumed was happening anyway. I thought it was ridiculous to be putting up a sign. That's like, thank you for driving safely. Everybody does that. So I thought it was silly to be advertising something that the public assume we do, and nobody from the public comes into a dental practice and asks, "Can I check your infection control processes?" In fact, a lot of dentists buy a practice and don't even check the infection control procedures in those practices, and end up actually being a little bit deceived, or how old is this autoclave? But ultimately, the public expect that I'm going to a hospital, I'm going to be looked after. I'm going to a dental practice, I'm going to be looked after. So interesting you should say that the naivety of the dental profession in terms of treating the people who put their hand up and saying, I've got HIV differently, is totally wrong. We should be treating everybody the same.
Yeah, I think it is still this more the feeling, not the knowledge. So, like, there are many studies that show that dentists actually do know a lot about HIV, and the facts are correct that they know. But still, when a patient comes into the practice, then over 60% are reluctant to treat them or would treat them differently, even though they have the correct knowledge. So, it's more of a societal thing, I think, than the education.
So, where to from here in terms of perception and awareness in both in the dental community and the general population?
Well, I think the best thing we can do is just raise awareness. I know this is a very popular phrase nowadays, raising awareness, but I do think that this is the key aspect of it. So just talk about it and let people know that this is just for the patients as well as for us. This is something that we should know. This is important for us to know because there are side effects to the medication. There are added effects to the illness itself that we should know, that we should prepare ourselves for. That's why it would be amazing if just, patients felt safe enough to tell us. And if we could, as dentists, as doctors, just kind of step over this societal preconception that we have to treat them a little different.
Fascinating. What are some of the, I guess, the myths out there, the common myths about HIV that the public has this perception about?
Well, I think that one is that the ways of transmission are very specific, and even though people tend to know the ways of transmission, they still are more afraid sometimes than they should be concerning HIV. So, even though all the body fluids can have detectable HIV particles, not all the body fluids are transmitting the virus itself. So normally, the only body fluid you should have in a dental practice is blood and maybe saliva, but saliva is not transmitting the virus. Only blood is the one that would transmit the virus. And with a patient who is actually on the meds, on the right meds, in the right dosage, the little particles of blood that might spread are not really relevant. So the viral load is so low that could not really infect anyone. And for a transmission to happen, it's also very important that the blood comes into contact with blood or with mucous membranes. So as long as the dentist, wears the mask, wears the protective eye gear, it should not really be something that's so likely to happen.
So the images that a lot of people have about HIV and AIDS is that once somebody gets it, it's a very early death, a la Freddie Mercury style. But people live now for decades with HIV.
Yeah, so with the introduction of antiretroviral therapy that started in 98, the first therapy regimen were published in 98, we can see a near to normal life expectancy with these patients now. So actually it's not what it used to be. I know this is something that changes over time, and I think this is a relatively short, time frame in which there was a huge change. So maybe some people still have a hard time adjusting to the fact that HIV positive patients can live near to normal life expectancy, and even the quality of life can be close to normal. Obviously, you have a chronic illness if you I'm sorry. It's like a chronic disease if you live with HIV, so you have to take meds. You might have, side effects of the medication. You also might have some co-infections or comorbidities linked to HIV. So I wouldn't say that the life quality is exactly the same as a totally healthy person, but there are so many people living with other chronic illnesses. So it's not just HIV, but anyone who has, for example, rheumatology or like rheumatologic illnesses. Sorry for my pronunciation sometimes.
No, not at all.
They would have to take meds as well. So like any medication can have side effects, not just the HIV medication. Anyone who has, for example, high blood pressure or some heart disease, they would have to take meds as well. It doesn't really make HIV special in that way.
So, medically, the antiretroviral therapy, what side effects should dentists look for that could possibly interfere with regular dental treatment?
Well, I am talking a bit more about this in my course, but I think the most important is the dysregulation of calcio homeostasis, so like calcio-phosphor homeostasis in the body, which could lead to loss of bone density. I think that's the most important for us as dentists because we work closely with the jaw, and the jaw is a bone that is linked with a higher rate of, sorry, like bone metabolism, like compared to other bones in the body. So that's why changes in the homeostasis of the calcio system is more relevant, I think, in the jaw as some other parts of the body. And this occurs a little bit by initiated by HIV itself, but also the medication can start impacting the patient's bone system. And obviously, if you want to work with the bone or just change aspects of the bone by implants or by extracting a cyst or something, then you should think about this, that the healing process would be a little different. So that's something that I would, for example, check with my patients if I'm planning a bigger operation that impacts the bone itself.
Okay, so it's just a matter of post-operative observation, or also are there some procedures that we would say, well, this could be a risky procedure because of the medication, or is it just like stopping your warfarin when you have an extraction?
It's more like the stopping the warfarin if you have an extraction, although warfarin is something I would check with the GP. And actually HIV and antiretroviral therapy can as well affect the blood system of the patient, so like it is a little bit similar in that way as well. Most of the treatments that dentists would usually do not have a worse healing rate than in HIV positive patients than in the normal popularity, or like a general population. Sorry.
Yeah.
But still, I just would, just to be sure, because whenever something happens and then the patient raises a concern, then I would be someone who wants to be safe and wants to have checked all the possible sources of conflict in beforehand.
Yeah. It's much easier to, as a friend of mine says, it's much easier to write a prenup before the divorce than try and write a prenup after the divorce. And it's the same with the surgery. If we dive in without getting all the facts firsthand, that's when we end up in trouble. And so
Yes.
It's just a matter. But you mentioned that some HIV patients are disclosing that they have HIV and they're on the medication. But as you said, the risk is that there's a lot of people out there who still don't know that they're HIV positive. Why is that?
Well, I think that there is no general testing requirement for HIV, so there are lots of patients who probably would never have the opportunity or the need to test themselves. I mean, people like my generation would try to be aware and try to get tested if you have a lifestyle that kind of makes you more susceptible or more likely to get the disease. But I just think that there is no general requirement, which is also, patient's consent is always very important. So I wouldn't want to like generally require everyone to test HIV because it is a private thing. But still, I think this general testing is not a thing, and that's why there are a lot of people who do not know, or a lot of people think that they are not likely to get HIV. So that's why they don't go and test themselves. But there are actually some notions that a point of care, quick HIV testing system could be, developed for dental practices. And there were some studies that, tried to find out how patients were reacting to that. And actually, most of the patients said that they would be okay with a bedside testing for HIV, which would also change this a lot. But that's something that I do not right now know about being a thing, just like a thought that might, happen maybe soon, hopefully.
Yeah, I guess, on the one hand, it's if you're not living that sort of lifestyle, being high risk, having that test is of no surprise. You're going to get you expect a negative result, but there is a responsibility to your community, your family as well, to be aware of your health status, just in case.
Yes, I mean, in Austria, we require, for example, every patient who comes into hospital for a major operation to get HIV tested and hepatitis C tested. And most of the time it comes back negative, but that would be, for example, a point where someone would find out their diagnosis if they have to. Or I know many general physicians just ask their patients when they are due for their general checkups if they want to include HIV or other infectious diseases into the checkup just to see if they have it. And, many patients say, yes, of course, just include it. I'm not going to be positive anyway. So that's a point where they could find out, but some of the patients say no, they don't want to know. And that's also something that doctors accept then.
Interesting. Still a very interesting part of healthcare is HIV, and just making sure that we keep our protocols up in terms of dotting our I's and crossing our T's, and being aware that there is the opportunity there that somebody may be a carrier or a sufferer of HIV and not be aware of it. Now, Barbara, you mentioned to me also that you have recently branched out into CPR education as well. Can you tell me a little bit more about that?
So I've actually done this for a little while now. I think it's 2 years.
Mm-hmm.
There was this opportunity through my university that I was able to get into teaching the general public on first response and CPR. And I've enjoyed it a lot. So I became a volunteer member of the group, and I just kept on going even after the university course ended. I think that's very important because, by admitting HIV, by starting CPR at the right moment and just reacting quickly and not being afraid of, starting pushing, you can do so much difference. And that's what I am trying to do, to take people's just the fear to, touch and start. I think that's what I see as an aim in all these courses that we do.
So when you studied CPR, did you find that there is a resistance from people to be educated in administering CPR? Is that
not in the courses itself. So whenever we teach, I feel like people are very interested. They ask a lot of questions and they want to know. But I think in the real life situation, when you get there and you are afraid and you are a little bit in panic as well, a lot of people, hear this. It's not a myth, it's actually true, but they still hear that, you could break ribs and it's a crashing sound and something like that, and then they are afraid of that. But if you voice this and tell them that yes, you are very likely to break ribs if you do it correctly, especially with older people who tend to have a CPR-like situation or come into a CPR-like situation more often than younger people. If you voice this and you tell them, yes, this might happen, but still not admitting CPR is worse than just being afraid of the cracking noise. That's something, I think the cracking noise is something that most people are most afraid of.
So the cracking noise is the sternum and the ribs? That's what's happening?
Yeah, so with older people, the cartilage that connects the sternum to the ribs tends to get denser and just less elastic. So if you push on the sternum, then this definitely will crack and just give this cracking sound that most people are kind of weirded out by. But yeah, many times with older people who have less bone density, the ribs can break as well. But most people, what they don't really think about is when you push on the sternum, the ribs break to the outside and not to the inside. So like the ribs puncturing the lungs and making a bigger problem is less likely. And we always say that pushing is better than not pushing.
Oh, for sure. So give me a crash course in CPR. What should I do? Somebody's obviously having a breathing difficulty. They're having their heart's struggling. What should I do?
Well, the most important thing is, in every situation, just check if you are safe to help them. So if they are lying in a water puddle and there is just some electricity coming into the water puddle, then obviously you have to think about yourself. So like 2 patients are worse than 1 patient. We always say that. So first check if it's safe to help, and then obviously approach the person, try to, talk to them, get a response, and you mustn't spend too much time on this. Then check the breathing, and if the breathing is non-existent or not sufficient, that's also something that we try to teach our patients, like how to realize which type of breathing is not sufficient enough. Then you have to immediately call for help. That's something very important. Like you cannot do this alone for a long time. Call obviously the ambulance as well. And in Austria, we are very lucky that in situations like this, the ambulance takes 8 minutes on average. That means for every ambulance that comes here in 12 minutes, we have some that comes in 4 or 6 minutes. And just, start pushing. Free the thorax from clothing and everything that's on it. Start pushing. And if there is someone around, then instruct that person to go and get the nearest AED, I think you say in English, the defibrillators.
Yes.
Yeah, and that's just, you start if you have a breathing mask, then you do the 30/2. But if you do not know the person or do not have a safe way to do mouth-to-mouth resuscitation, then just push. That's important. That's the most important.
Yeah. So when do you see a result from the pushing? Like when should you say, oh, I've been successful in resuscitating or reviving this person?
Well, we tell our clients or like the general public that we teach, we tell them that there are 2 ending points of CPR. It's either the patient tells you, ow, this hurts, stop, because it is hurtful, and the patient will tell you to, bug off, or if the ambulance arrives and they take over. So yeah.
Just keep going until one of those 2 things happen.
Yes. One thing that we also advise people to do is to switch at least every 2 minutes, but also to just admit if they are tired, because, some people are trying to push through and trying to just tell everyone that, yeah, I'm strong, I can push, but there are studies that even the best educated and best qualified people for this do not go longer than about 2 minutes. After 2 minutes, the quality of CPR just declines. And that's why at least every 2 minutes, when the defibrillator does a check every 2 minutes, if there is like a heart rate, like a shockable rhythm, and we tell our clients to, whenever the defibrillator says, please do not touch the patient, analysis running now, then they should switch in those moments, because they cannot touch the person anyway. So there is a perfect time frame for switching.
So if I was to begin, am I better to begin with the defibrillator or with the chest pushing and the CPR?
Well, you should connect the defibrillator as soon as you can, but you usually do not have the defibrillator right there. So just start with the pushing, because that's very important. And I would advise to send someone else for the defibrillator if you have anyone else around. And if not, I mean, this might be different for every country. As I said, in Austria and especially in Vienna, we are very lucky, because not just the ambulance, but also police has defibrillators, and even police on bicycles, they have these mini defibrillators. So the police usually arrives even before the ambulance. So we usually have a defibrillator at the scene of the accident, or just the scene of the happening, within a few minutes.
Well, I remember years ago, Australia's richest man was kept alive because he had an accident, and the passing ambulance, the nearest ambulance, was carrying a defibrillator, but a lot of ambulances weren't. And when he found that out, he just paid for every ambulance to get a defibrillator. So this is 35 years ago, I'm sure that happened. But now they're quite inexpensive in terms of having them. Every dental practice should have one.
Yeah, I don't think every dental practice has one, but I think what's important to research is where the nearest defibrillator is. In Austria, we have a lot of public defibrillators, so like any metro station or any train station, then malls, or I don't know. We have even these public columns, like just out in the street, where there is a defibrillator. And actually, if you take the defibrillator out of the box, then that also alerts the central system. So like the system knows that there is a defibrillator being taken out of the box. So in this way, I think we are very lucky. I cannot speak for every country. This is what I've, learned and taught to the public. This is the system I'm working with. But I think it's quite similar. So like, I think most of the countries are just thriving to have as many defibrillators as possible. Obviously, in the countryside, it's different.
Yeah, well, where I live, in a village of 150 people, I'm just trying to think, where would the nearest defibrillator be? I'm going to find that out.
You have to, yes.
Yeah.
I know the 3 closest defibrillators to my apartment.
Yeah.
I know in which direction.
I bet you there's one at the petrol station. There's probably one at the hotel, and there might even be one at the post office. Where is the nearest defibrillator? That's a really good point, and I think that should just be a public awareness sort of community.
Well, that's what we're working on.
Community advertisement. Like, where is the nearest defibrillator in case it's needed?
Yeah.
My wife's father, he died of a cerebral aneurysm in his it's not cerebral, an aortic aneurysm in his abdomen. So he very fortunate. If you're going to die, that's the best way to die. He was dead before he hit the ground. But the person who discovered him was had done a CPR course. So this guy was working on him, trying to revive him. And because he was he'd been cycling, he stopped his bike, put his bike up against a tree, and then he just went bang. And so he didn't actually recognize who it was because he was still wearing his helmet and his glasses. But this person who stopped to help said and it was mentioned at the funeral, if you're going to need somebody to give you CPR, this guy was the guy. But unfortunately, he was past CPR when that happened. But it's a knowledge that
Yeah.
I think we should all, if we haven't got CPR skills, we should all learn them, because we never know whose life we're going to save. And it's not so much their life, but it's also if we can keep somebody alive, they become a grandparent for longer, they become a parent for longer, and that's always the shock of death.
Yes.
Is the effects that it has on families, either expected or unexpected. So having my mother's father died of a heart attack, and it is a good way to lose a relative, because it's quick, it's sudden, and it's not drawn out, and there is
Yes.
dignity in a quick death, but it's still no fun. Death is no fun for anybody.
Yes, and the death that we try to, the death rate that we try to lower by this course is the sudden heart stop, like the sudden stop of the heart. I think if I translate it correctly.
Yes, you have.
And this can occur with anyone. So like sometimes not likely, but it can even happen that like a person who is 20 or 30 or 35 just, falls over, and then all the people around them, if they start CPR soon enough and they are lucky to get a defibrillator there in time, then sometimes you can save that patient, and that's a very young age. So like those people then maybe go on to start a family and just, you said, like become a grandfather, grandmother, and just have a long, lovely life. And that's something that would not be possible without CPR.
Yeah, and I think CPR is something that we all need to have a wake up call about, and maybe there needs to be more public awareness. If you don't have CPR skills, why haven't you got them? Because even if it's just in your own home that you save somebody, or keep them alive until the ambulance gets there as well. That's really, really important, because I've got a friend who was very lucky. He had a heart attack in his early 40s. The initial thought was to drive him to a hospital. They got an ambulance a helicopter to fly in and get him, saved his life. But he was able to identify exactly what was happening. He knew. He said, "I'm having a heart attack," and the family said, "Well, we'd better drive you." He said, "No, just call 911 and get an ambulance here." And the quickest ambulance was, fortunately for him, helicopter.
Yes.
And he's still going, 30 years later now, as a result of that. So
that's amazing.
Yeah, and as I said, he's in his third career. So he was a dentist, and then he was a dental coach, and now he's a grandfather. So and
that's
he
amazing.
loves the grandfather role even better. Barbara,
Yeah.
It's been great talking to you. Thank you so much for sharing your story, and the fact that even at such a young age, you have covered so much in diversity in the dental profession, from facial aesthetics to becoming a doctor to becoming an oral surgeon and looking at max fax specialisation, as well as CPR. You did mention that this is it, that you now just want to start a working career rather than an educational career. And I know that with that level of knowledge, you're going to be a person who's going to be in demand in the in that career of max fax. That's for sure. I was talking to another dentist as well in America, who same thing. She's also has a max fax specialty, and also very much into facial aesthetics. Again, just with that merging of putting people back together, but also reducing the amount of post-operative surgery. So it is a big field. And of course, as you said, with the orthognathic part, which is elective surgery, people elect to improve their skeletons. I think that's a really big career move for you. So, Barbara Bulla, The best way for people to get in contact with you is email and LinkedIn.
Yes, mainly LinkedIn. If you search my name, Barbara Bulla, there will be a quite long and for some people a little distracting title, but yes, Barbara Bulla, you should find me.
And that's the easiest way to get in touch with her. Well, Barbara, thank you very much. And you're also an educator with the Advanced My CE platform. So thank you for being a part of that. And that'll also be mentioned in the notes afterwards as well. Barbara, thanks for joining us on this Monday morning your time. I really appreciate you taking the time to do that. And thanks for sharing your wisdom with our listeners on the Ultimate Dental Podcast.
Thank you very much for inviting me. It was a pleasure talking to you.
Thanks, Barbara.
Thank you for tuning in to another inspiring episode of the Ultimate Dental Podcast. We appreciate each and every one of you for being a part of our dental community and joining us each week on this incredible journey. If you found value in today's episode and you don't want to miss out on future episodes packed with expert insights and actionable strategies, here's how you can stay connected with us. Firstly, hit that subscribe button. Whether you're listening on your favorite podcast platform or watching on our website, subscribing ensures you'll never miss an episode. Secondly, share the love. If you know a fellow dentist or colleague who could benefit from the wisdom and knowledge that we share here, please share our podcast with them. Also, please share the podcast on your socials by simply clicking on the social icons wherever you view or listen to this podcast. Together, we can all do our bit to elevate the dental profession. And finally, stay engaged with us. We love hearing from you. Your questions, comments, and feedback fuel our mission to provide the best content for your professional growth, your personal growth, and for your practice growth. Remember, your journey to creating a dental practice and a business life that you love is our mission, and we're excited to be your trusted guide along the way. Thank you for being a part of the Ultimate Dental Podcast. Until next time, keep smiling, keep striving, and keep on tuning in to the Ultimate Dental Podcast.